Okay, welcome back. So we've gone through my Echo 2 slides, just skimming over regurgitation a little bit, reminding you about preload. We've done this a couple weeks ago, but I wanted to refresh your memory. Now we're going to get to the actual slides of this week, which is based on mitral regurgitation first. This is going to be under week 7, although you guys are in week 8. You're almost done. Congrats. Okay, we're just going to week 7, and here we go. So MR, as you'll notice, I will skim through some of this because I explained a lot of it in the last lecture video. So mitral regurgitation, which is also known as insufficiency, right? Another word for regurgitation is insufficiency, is a disorder of the heart where blood leaks back from the LV into the LA through the valve during systole when it should be closed. This is the most common form of valvular heart disease. You will see this a lot. Can be very mild, can be very severe. The more severe, the more of the end diastolic volume of the LV will empty into the LA instead of the aorta. We want it to go forward into the aorta, not spill backward. The more of it that's spilling backward and not even getting to the aorta, the worse the situation is. Think about it. If all of that oxygenated blood that's supposed to be getting out of the aorta just sits in the LA because it's going backward, the rest of your organs, right, and your extremities and even your brain, these areas are not getting the oxygen that it needs to continue to work properly. What causes MR? We discussed the leaflets and also supporting structures, so chordae tendineae, papillary muscles, and that includes the adjacent myocardium as well. So whatever muscle in that area is holding on to the papillary muscles. When we talked about myocardial infarction in week 5, I believe, heart attack, I gave you an example of what can cause MR, right? If you have a myocardial infarction and that part of the wall, that one wall segment, is weak, and there's a papillary muscle there, right? Because that wall is weak since it's not getting blood. There's ischemia, right? If that wall becomes weak and that papillary muscle ruptures easily due to that, now you have a situation where there's MR, right? Or a chordae tendineae ruptures due to that. That's how you get MR. That's one example. Conditions that can result in MR, meaning mitral regurg, include all of these. Okay, you can read through it yourself. The biggest one is rheumatic heart disease, most common. You have MVP, which is mitral valve prolapse, we'll talk about. Coronary artery disease, calcification of the mitral annulus, endocarditis, HCM, which is hypertrophic cardiomyopathy. Think thick walls, right? Connective tissue diseases and disorders, and any condition that results in the LV dilating. Conditions that's likely to result in acute MR, meaning like just quick onset MR. It's not happening over time. One is that trauma of a ruptured papillary muscle or chordae tendineae that we talked about just now. That results in a flail leaflet causing MR. Another example is if the leaflet itself gets a hole in it. So don't know if I told your class, I'm drilling into you to floss every night. Why? Because your gums are right next to all of your capillaries, right? There's a lot of blood flow right there by your teeth. If you do not floss and you let food sit there, you have a very icky situation where bacteria can easily get into your bloodstream, which then goes to your heart. If you end up with endocarditis in the heart, right? This is like infection of the lining of your heart, essentially, in the valves. You can end up with vegetations on the valves, which are gross little bacterial and viral things that stick onto your valves. That can lead to a host of issues, one of which is perforation. This bacteria can eat through the leaflet and cause a hole. This can also be done through non-sterilized equipment, right? That's why it's very important that when you go to the dentist and things like this, that they really get in there and clean those tools. That's why they're very serious about that. This is an example of a ruptured papillary muscle, right? It's not on the wall like it should be. It's kind of flailing off. We can see that. Presentation, we discussed all the symptoms you might see. Here they are again. When it's mild or moderate regurgitation, you might not see the symptoms as much, but the more severe the regurgitation, the more severe the signs and symptoms are. We talked about backflow of blood, right? First, the LA will dilate due to excess blood leaking back into the atria. This increases the volume and also increases the pressure. Next, you will see an LV that is hyperdynamic due to Frank Starling's law. Remember, I said increased antegrade flow, increased forward flow, because blood from the pulmonary veins comes into the LA, plus all that abnormal regurgitation blood from the LV. And then the next time the valves open, way too much blood coming into the LV compared to normal. That stretches the muscle. That leads to increased contraction. MR can result in decrease in cardiac output due to the fact that, like I said, blood backing up into the LA means that's less blood that gets to go out of the aorta. The worse the regurgitation, the less blood is able to come out of the aorta to feed the rest of the organs in the body. That means decreased cardiac output. The less blood goes into the aorta and comes out of the aorta to the body, that is lower cardiac output. Right, because of dilation, you'll get this AFib. And again, due to dilation and increase of pressure in the LA, you get it back up into the lungs, and this results in pulmonary hypertension. This is a good slide. Summary of the changes of mitral insufficiency or regurg. Dilated left atrium, dilated left ventricle over time. Hyperdynamic LV, increased LAP, which is left atrial pressure. Decreased cardiac output. You will see AFib and other types of arrhythmias possibly. Pulmonary hypertension, edema, and an enlarged right side over time, right? And this is what I mentioned. MR results in increase in preload. That's filling of the LV. Okay, we talked about rheumatic fever a lot with all the other valves, right? This remains the same. Rheumatic disease is probably the biggest cause of MR. That is something I want you to write down. And this is just teaching you a bit about rheumatic fever, which we did speak about last week. Echo findings. You may be able to see some things that will clue you into there being rheumatic heart disease. Thick MV leaflets, right? What's the word I'm looking for? Very bright, echogenic, my apologies, leaflets, right? Very echogenic compared to the rest of the heart on echo. That is a sign as well. Commissural fusion, the chordae fusion, shortening of all of these things will be signs of rheumatic disease. Mitral valve prolapse. So what is MVP? This is posterior displacement of one or both leaflets towards the LA and systole. Right, I'll show you what that looks like. Prolapse, you really want to be perpendicular to the beam to see this, so you really want to see this in parasternal long axis, or else you're not really going to get it to be an accurate image. Big sign of mitral valve prolapse, this is important, systolic bowing of anterior leaflet. That means it's dipping back into the LA during systole. Usually this is flat, but here we're seeing it's bowing backward. These are other terms we use to describe MVP, but most commonly used is really just mitral valve prolapse. Very common to see, even in young people. Taking a water break. Okay, so what this is showing you is the difference between prolapse and a flail leaflet. So when there's prolapse, this is a normal valve leaflet, right? This is 3-chamber. And you can see that the tip of the valve is still pointing towards the LV, right? It kind of opens out into the LV. The same thing should be true here, but instead with prolapse, we have this bowing into the LA. It's kind of back, doming backward in here. But one thing that remains the same with prolapse is that the tips is still facing the LV. When you have what's called a flail leaflet, which we discussed with the myocardial infarction example, what happens is the entire valve, so including the tip of the valve, instead of being up here facing the LV, the whole thing goes backward into the LA, the whole valve leaflet, which means now this has an opening. Most patients are asymptomatic when it comes to this. Chest pain can be variable, but usually it's a sharp pain or a pressure sensation. There may be difficulty breathing, fatigue, anxiety, palpitations, and arrhythmias is usually what sends patients to the doctor in the first place. And you may see syncope and dizziness in these patients. Don't worry so much about this. And here are some complications of mitral valve prolapse. So you have progressive regurgitation. The worse the prolapse, the more regurgitation you'll get. You can end up with this bacterial endocarditis. I will say, as a general rule of thumb, on any valve that has something abnormal going on with it, right, they are more at risk to developing an endocarditis or having a thrombus stick to it or any of those things. That increases their risk. TIA, transient ischemic attack, you can think of that kind of like a mini stroke. Consider it that way. In this case, an emboli, blood clot, right? An embolus is a clot that tears off and starts traveling somewhere. This causes a brief blockage in an artery to the brain, usually with no permanent damage, but it's enough of a blockage for us to be able to see. And sudden death is another complication, but very rare. That's not usually something you see with prolapse. There's often no specific treatment of this mitral valve disease, even if there's chest pain, right? Majority of physicians agree prophylaxis should be given to patients before even minor surgery. As I said, any valve that has any issue with it, such as MVP, you're instantly more at risk for developing something on the valve or something else going wrong with the valve. So they already have an increased risk of endocarditis by having MVP. When you go to the dentist, even with smaller basic surgeries, you are at very high risk to get endocarditis because of what I explained about the blood in that area and your blood vessels being very close to the surface. So even before a minor surgery, physicians do agree that patients should be given medication to prevent infection from happening, just to be sure, especially when somebody has an MVP like this. If the MR resulting from MVP is super severe, then at that point, you might have to replace the valve, but that's sort of, last case. Other abnormalities that's associated with mitral valve prolapse, so we talked about MR already. You might even see tricuspid valve prolapse. You can look at both valves and see if both are affected. And then you have something called Marfan syndrome. These are patients or people you might have seen just walking past you in the street. They generally tend to be pretty tall, pretty slim, right? And have long limbs. So longer arms, longer legs. And these patients have a connective tissue disorder. That's what Marfan's is, right? And what that does is it also causes other issues in the body, and that includes the heart, right? Anywhere where there is connective tissue. ASD is also associated with mitral valve prolapse, which is atrial septal defect. Pitfalls, false negatives, false positive. Essentially, you can think that there's prolapse when there's not, or you can think everything's fine, but there is prolapse. So you have to be careful, really diagnose in plaques where you're perpendicular to the beam. You want to make sure you place colored Doppler, see if you see regurgitation, because if you do, pretty good sign that in tandem with what it looks like on 2D imaging, there's probably prolapse. We usually don't want to diagnose that there is MVP in the scenario that there's a lot of pericardial effusion, because the entire heart swings in the case of effusion that large. And if you're doing an M mode of the mitral valve leaflets, let's say, and what you're looking for is doming posteriorly of the mitral valve leaflets in systole, you might notice that in systole, the entire heart swings posteriorly. So it might look like that's what you're seeing on echo, on M mode specifically, but it's really not. So we tend to diagnose this more when there is not a pericardial effusion. Coronary artery disease, right? So right now, I'm just reminding you guys where we're at. This is labeled number 3. We're looking at basically causes of mitral regurgitation, okay? So we talked about rheumatic fever as one cause, mitral valve prolapse, and we talked about explaining that. And now coronary artery disease. This is another thing that can cause mitral regurgitation. This was week 5's lecture. If you want to read up on that, this is essentially, our ischemia lecture when we discuss blood not getting through the coronary arteries that give blood to the myocardium of the heart due to the fact that there's an occlusion in the coronary arteries. Cholesterol, fats, plaque, all these things are substances that can block those coronary arteries that will then cause coronary artery disease. This coronary artery disease is what can result in an MI, right? Or any ischemia, because blood is not getting to the muscle. We talked about that a few weeks ago. Once CAD leads to MI or ischemia, this can then result in that papillary muscle tearing off, the chordae tendineae being ruptured, the LV muscle next to those areas not functioning, and those can cause MR. This is an example of what that can look like, atherosclerosis. And this is plaque filling the vessel. So notice how small this lumen is now. You barely have space. Blood is not going to be able to get through here. This is just saying of the 2 main papillary muscles, there is one that gets more blood from more vessels than the other. So if you only get blood from one vessel and that gets occluded, or you have a clot in there, or if you have plaque in there that's stopping blood from getting through, most likely this papillary muscle is the one that's more likely to become ischemic and not get blood going to it. Anterolateral has 2 arteries that it can get blood from. So if one gets clotted or occluded, it still has a chance to work properly. Still has a chance to receive blood from the other artery. Okay, this is just showing you what happens in the case of the papillary muscle getting displaced due to the muscle getting weak here, right? It's kind of pulling these valves taut and they're not able to close because this is now bulging outward. It's not squeezing the same in systole because the wall, let's say it's akinetic or hypokinetic, right? It's not squeezing in like it should. And when it squeezes in, these valves should touch and be closed. If this is extending outward because the wall is maybe not moving in systole, now these 2 valves can't touch because they can't stretch to meet each other. They're a set size, right? And now you have this hole that regurgitation can come through. Most common cause of papillary muscle dysfunction that can then cause MR is scarring of that muscle from coronary artery disease or after a heart attack. The thinning and dilation of the myocardium then contributes to the shortening of the mitral valve apparatus. So that means, remember I gave you the example, if the LV wall starts to pull apart because the LV is dilated and there's too much blood in there, the valve leaflets don't then grow to touch each other. They remain the same size. So they continue to get pulled apart and pulled apart and pulled apart as the LV gets larger and larger. And now they're in a situation where when they're supposed to coapt and close and touch, they don't. And now you have a big hole there where there was once touching valves. Okay, another thing that can cause mitral regurgitation is what's called MAC, also known as mitral annular calcification. So the annulus is kind of like the MV ring. It's what holds the mitral valve in place, that area of the myocardium. So that's what your annulus is, and that area can calcify. That begins near the MV ring and can extend towards the leaflets. Calcification is located in the submitral region, so usually a little bit below the mitral valve. Aortic valve ring can also become involved, so you can look at both valves to see what's happening, but MAC is a very common thing that you might see. Due to this calcification and fibrosis of the annulus and the surrounding structures, the leaflets kind of shorten because they've gotten stiff. They don't move as well. And this causes mitral regurgitation. The posterior portion of the mitral annulus is usually most commonly involved, and you'll see that on echo. This is the annulus here that connects the leaflets to the wall. So this whole area. They're saying both of these can be affected, but the posterior, most common. And this is what that looks like. These very chunky areas, very echogenic, right? Very thickened areas. That's what MAC looks like. You can see this in apical 4, plaques, parasternal short. It will be apparent in all views. And you can see here in plaques, this is the anterior leaflet and the anterior annulus. This is posterior leaflet, posterior annulus, and here the posterior is most affected. Okay, another cause, which we talked about, less commonly though, is bacterial endocarditis. When bacteria eats through a leaflet, that example, that's what can cause MR here. MR is usually acute in this case rather than chronic because usually once the disease clears up, like once you're treated for the endocarditis and it goes away, everything usually clears up after that point, the risk of getting MR. Often referred to as subacute bacterial endocarditis. We'll talk about vegetations and prosthetic valves next week, so I'm not going to get too much into this. But the infection, once again, can manifest itself as a vegetation, which is like this little gross flailing thing on the edge of a valve that is actually bacteria. People who may present with this, a lot of IV drug abusers most commonly, patients with rheumatic heart disease, any patients with anything wrong with their valves already, they're more likely to end up with this disease. Why is it a problem? Well, that little piece of bacteria that's on the edge of that valve that's flailing around, that can embolize, just like a clot. That can tear off of the valve and end up going somewhere else, like the brain. You can end up with abscesses, right? Abscesses, that's something that you get when you do have some sort of bacterial infection. You get a ruptured chordae tendineae that can happen, or severe MR because of this bacteria eating through the valve. Again, we'll talk more about this next week. You'll see thickened leaflets, very bright, and the valves look shaggy, like they're eaten through. Okay, this is that vegetation here. it literally does move on echo. You'll see it. I'll post videos so you can see that as well for next week. And group 6 that can cause mitral regurgitation would be cardiomyopathy. So if you put together the words, right, your prefixes here, cardio, heart, myo, muscle, pathy, disease. So heart muscle disease. This we'll get into in Echo 2 some more, but just an intro here. There are 3 main ones that we like to discuss. There are a few others, but those are the main ones. One of which is called hypertrophic cardiomyopathy, and that has to do with thickened walls, right? In some cases, it's what's called concentric, which means all of the LV walls are thickened. In other cases, it's just the IVS, for instance. In either case, if the IVS is thickened, you have a situation where the wall of the heart, that IVS, is now so thick that is protruding into the LVOT, where blood is supposed to exit the left ventricle and go into the aorta. If it's protruding into that area, that means you now have less space for blood to flow through. That's kind of like a stenosis hemodynamic, right? And what can happen in this case is the mitral valve leaflet, the anterior one, gets swept up into the LVOT, causing systolic anterior motion, known as SAM. So this is what that looks like. This is plaques. Look how thick this wall is. And you can see this is normally not this small, right? This LVOT, blood is going from here through the valve to the LV through the aorta. But this space is tiny. So that's one of the issues that's happening. And because it's tiny here, think about what we talked about in stenosis. The smaller the space, the higher the speed and pressure with which the blood usually has to go through. And if that speed and pressure is high, this valve leaflet is now getting sucked into this area due to all this blood shooting through here, specifically in systole. So remember, in systole, these valves should close in towards the middle. But if during systole, these walls squeeze, blood shoots out of here, instead of being connected to the posterior leaflet and closing together, this leaflet here starts to touch this wall. It gets swept up into the wall. This is what that looks like. You can see here, instead of being flat after the ENA, you now see the anterior leaflet hitting the IVS. This whole thing is IVS. And then this up here is your RV, right? We'll get into that more in Echo 2, but that's something that you can see. And if you have this leaflet moving up in systole when the valve should be closed, look, you have a space here now. Blood can move into the into the LA during systole, which is regurgitation. The valves are no longer closed in systole. And 7. Another thing that can cause mitral regurg that we mentioned, connective tissue disorders like Marfan's. This causes abnormalities of multiple things, including the cardiovascular system and musculoskeletal system. Oftentimes, you'll see MVP, prolapse, which causes mitral regurg, right? And over time, this can rupture the chordae tendineae. Dilated sinuses of Valsalva, we'll talk about in Echo 2. Treatment of chronic MR. So, MR is treated according to severity of the symptoms and severity of the regurgitation, right? With increased afterload, the LV has to then generate higher pressures, which results in greater regurgitation. Think about it this way. Don't read this for now, just listen to what I'm saying, right? What this is saying is that depending on the pressure and depending on how much the LV has to squeeze with how much power, that determines how severe the regurgitation is going to be, right? If you have the aorta in front of the LV, we talked about aortic stenosis, right? That's an increased afterload. LV has to work hard to push blood out. It has a smaller space. Remember my hose example. If I put my thumb over half of the hose, Now all of the same water has to shoot out of just what's left, just the hole that's left. And that's usually with more pressure and more velocity, right? So that's what the LV now has to do. To work against the pressure of the aorta, it has to go past the pressure of the aorta with its own pressure to get blood out of that valve. So now it has to work harder. It has to have a higher pressure and squeeze with more power to allow that to happen. Great, now that gets blood out of the aortic valve, but what happens if the mitral valves are not closing during that time, right? Because that's systole. LV squeezes in systole to get blood out. If LV is squeezing very hard with a lot of pressure, a lot of power in systole to get past that stenotic aortic valve, but the mitral valve behind it is still a little bit open when it should not be, some of that blood is going to shoot back, right? The difference is, now since the LV has to work hard, that blood that shoots back is going to shoot back with a higher pressure and velocity too. So the same way that the antegrade flow, right, the normal forward flow of the blood has to have an increased pressure and speed to get through the aortic valve from the LV, that same blood is going backward in the LA. So the higher the pressure, the more the LV has to work because of what's going on in front of it, the afterload, the higher the pressure and velocities with which blood will back up as well. Because what's causing it to back up is the pumping of the LV. It's just that the mitral valve is not closed. It's open, allowing that blood to spill backward. So eventually, right, as this gets more and more and more severe due to higher and higher pressures, for instance, then treatment needs to come in, right? Patient may be given drug therapy. For instance, another example of afterload can be hypertension, right? High blood pressure. It has the same effect as the aorta being stenosed or the valve being too tight, right? Because the aorta is connected to all these other blood vessels, all these arteries. If there's a high pressure in those arteries, right, if they're constricted for any reason, if there's any plaque in those arteries, the LV is trying to push blood not just to the aorta, but through all those arteries too. That's why it pumps with so much power. It has a lot of places to push blood through. And if those areas have high pressures and have plaque due to high blood pressure and hypertension, LV again has to work really hard. So by giving a drug such as a hypertension drug to lower blood pressure, that can reduce how hard LV has to work. If that then doesn't work, now we're headed towards mitral valve replacement. And these are the valves that might be used, prosthetic valves. One minute, water break. Okay, so that was chronic regurg, treatment of acute mitral regurgitation. So same thing, there can be drugs given like high blood pressure medication in order to decrease afterload and all of these things to stabilize the patient. But usually in the case of acute regurgitation, you usually are going to need valve replacement because oftentimes the acute regurgitation is caused by that papillary muscle tearing off or the chordae tendineae being disrupted or bacterial endocarditis eating through the valve leaflet. All those things necessitate a valve replacement. So reminder of things that you will see on echo. Enlarged LA and LV, right? We talked about that. Increased LV we didn't quite talk about, but that's because after that enlarged LA, we know why that happens. Remember, increase antegrade volume because blood is always filling in the LA from the pulmonary veins, and blood is now backing up from the LV into the LA. So now LA has way more blood, even maybe twice as much blood as it should have. And every cycle, all that blood is trying to empty into the LV. That will then cause the LV to get big, right? So LA being bigger than 4 centimeters in plaques, LV being bigger than 5.6, which is upper limit of normal in plaques. Then you'll also see hyperdynamic left ventricle. We talked about why, that Frank-Starling law. The more stretch because of the more filling due to this increased antegrade flow, the more squeezing, the more contraction you get. right? And that leads to hyperdynamic LV, more movement. Okay, we'll also see dilation of the annulus. So as the LV gets bigger and bigger and bigger, now the annulus is pulling apart, which then leads to more regurgitation. So this is just like a continuous cycle, a negative feedback loop, right? The MR is causing an enlarged LA and LV, and the enlarged LV is causing more regurgitation, which then causes more enlarged LA and LV. It gets worse and worse over time. You'll also see what's called systolic bowing of the interatrial septum towards the RA because the LA is big. So this is what that looks like. I'll show you in a second. This is their dilated LA. Remember, LA to AO ratio, these should be similar in size. This is huge. This is about 1 to like 5 centimeters, probably 5 to 6. This is what your hyperdynamic LV will look like, right? A lot of contraction, a lot of movement in M mode. This is an example of bowing of the interatrial septum. This is specifically in parasternal short, and you can see this is LA, this is RA, and this is the interatrial septum, the IAS. You can see instead of being straight like it normally is, it's kind of bowing into the RA because the LA is getting full, right? So you're going to see that moving over to make room. Early systolic closure. So this is M mode of the aortic valve, right? We're used to seeing box line, box line, box line. But usually this box goes on for a longer time than this, right? This is shorter than we're used to, a smaller box. The reason for this is because of what we discussed with the blood being ejected from the LV getting split up, instead of all going into the aortic valve, some of it is getting into the aortic valve, some of it is being pushed backward into the LA, which should not be happening. Because less blood is going into the aortic valve, it's going to be open for less time, right? Soon as the LV has given the blood it has to give, the aortic valve will close. So if a lot of it, the more of it that's going backward, the less of it is getting through the aorta, the quicker the aortic valve is going to close. And the shorter this box will be. It won't be long like this. It'll be the short little area of open aortic valves. Okay, so we're going to pause here again. And in the next video, we're going to discuss Dopplers. Okay, so we discussed how everything looks on 2D and how to assess that and what the causes are of MR. Then we're going to talk about Doppler and how to assess severity. And yes, we're going to get into the equations and all the things that you all love so much. All right, be back.